This is the case of 81 years old female. She has biliary acute pancreatitis. She has a lot of comorbidities like diabetes, atrial fibrillation, and arterial hypertension. An MRI last March showed a large pseudocyst in 9 centimeter in diameter with the compression CBD. And the patient is here today for US guided drainage of the pseudocyst.
We just started the procedure, or I should say, Michelle, of course, has started the procedure. Has some, we discussed, you talked to the patient beforehand, and she is symptomatic actually. She has difficulty eating.
Yeah, she cannot eat very well.
So there's an indication, because in these patients with probably sterile walled-off pancreatic necrosis, one of the hot issues is always to choose the moment
Can we
to
zoom
intervene.
out? To zoom out.
Oh, here, depth.
Zoom, try and zoom out.
Out. Ah, voilà. C'est là pour agrandir et diminuer.
Okay. Ah, c'est là. Okay.
But of course, if you have 3 or 4 months to
better
recover,
image.
and the cyst is increasing and you have symptoms, then it's very unlikely to resolve without any intervention. So then you are, I think, allowed to take the risk of draining this, because there's a risk, procedural risk, of course, but also a real risk, a certainty, basically, to infect this collection. So you should be able and be willing to proceed to necrosectomy if necessary.
So I think
I
the
think
first
Michelle is struggling a little bit here.
we're trying to find, the fluid collection. So when you have issue like this because of autoanatomy here, there's some narrowing in the lower esophagus at a junction with the stomach. So you have to go back to basics. So at this stage, what you do, you try to find the celiac, the aorta, and the celiac axis, and follow them down until you see this is probably the best thing to do in this case. But we really
Yeah, I
have
think you're
issue
through.
here. I think I was able to get a little bit through. Now I'm going to gently adjust and try to get here. Here's the aorta.
Go into the stomach.
I'm going to follow it down.
Still in the esophagus.
Okay.
Okay. This is the cyst. Huh?
Here it is.
It's the same. Huh?
Okay, it's another one with a difficult angle.
Oh no, this
There it
one's
is.
much easier.
Ah, absolutely. So I think here the same rules apply. You can see here the fluid collection taking off from this area of the pancreas. So I think it will be very important to have a fluoroscopy image to kind of see what angle we have. And of course, we're going to use a Doppler. Hey, that's good. It's the same. It's like the twin brother
Yeah, definitely.
of the other one.
I think they collected them for us.
I mean, this is amazing. It's like a family reunion here. So what we're gonna do, same thing. We're gonna do Doppler, and the Doppler is right here.
Where is
And then you can see there's a small vessel
it's your
here
case.
that may be of an
Is the
issue.
patient for?
So we're probably gonna take. We're gonna probably go above the vessel to get access into the fluid collection.
Let's turn it off. Yeah.
Okay, we turn off so we don't get scared by the vessel.
This is also typical for wall-off necrosis, because actually you don't really see a pseudocyst. This is
Yeah.
not a pseudocyst.
Yeah.
You know, it's hard to delineate. It may be 5 centimeters,
Yeah.
it may be 10. It's really hard to tell because of all the solid components and the shadowing.
Yeah.
And you probably really appreciate the size once you fill it with contrast.
Can
I'll
I have
get
the
out of
19
way
gauge needle? Thank you.
and let Stefan do his job.
Do you think Michelle, in certain plastic stents or go for metal
Well,
stent in this
this
case?
look a little bit more
Acute
necrotic.
pancreatitis, wall of necrosis.
Yeah, this one looks more necrotic than the previous one. So I think in this case we may go with the lumina posing metal stents. So I'm going to try to find a good angle here. It seems to be a good angle. So I want to see my needle. Yeah, I don't know if you can see my needle. Well, the good angle is defined by the absence of vessel, obviously. And then, since you're already thinking about stenting, You want a very straight shot. So you can see here, I'm into the fluid
Yeah.
collection.
You're nicely in.
I'm definitely in. Yes, exactly. But really the most important information is stay away from the vessel. X-ray? Okay. So now we're going to remove the stylets. Same maneuver, we're going to get a sample.
I think this is the access needle, which you don't really need usually for
Yeah.
fluid collections.
We're going to get a little sample. Here it is. I'm interested to see what's going to come out, if something come out. You see, that's the problem with necrosis. Typically, there's not much coming out at the beginning. Okay? That's what I was afraid of. Nothing's coming out. So that's probably pure necrosis.
Probably.
So we could inject a little bit just to kind of have a roadmap of what we're dealing with. And make sure we're not into anything else. Yes?
Oh, there's a lot of resistance.
A little bit of resistance here. Okay?
Okay, some
So
more.
you see the content is much more thick,
No, contrast.
much thicker content here.
Copy.
And the image, I don't know if you've seen the MRI. It's the mirror image of the MRI. That's it. I think we're good here, huh?
Yeah.
Okay, so now what we're going
You'll
to do...
probably curl up. Yeah.
Okay, so we're going to now
So
put a
flush a
wire,
little bit.
a little bit of... We're going to get a wire cord into that. Here, and you see that same rule. I'm making sure my guide wire is in my field of vision. That's a key thing. When you do a US guide procedure, whether it's a pseudocyst, walled-off pancreatic necrosis, pancreatic drainage, you got to get that wire into your field of vision. That's probably the most important thing that I try to teach my advanced fellow. Keep going. Okay. So you can
Yeah,
see here, it's tracking down into the necrosis here. Okay, it's really like
Can you
way
follow
down.
the wire?
It's very big, huh? We're gonna try. I would like to get that wire maybe a little bit higher up.
And there are some fistula connections
Yeah.
to some regions.
Yeah, I'd
What
like
do you
to
think
stay.
about that?
I'd like to stay into the upper part of that fluid collection. Let's try to see if we can redirect the wire gently. Okay, we obviously this is a fistulous track. So which means we need to be very careful when we drain this. We don't want to go too deep because we want to stay into
Yeah,
the
that's
bulk
it.
of the
Oh.
necrosis. So yeah, that's good. I like that. Try that. Yeah.
But it's doubling up
Doubling up.
all the time.
Okay. So I think here is key to know exactly how deep you can go with your stents and use EUS to your advantage, because if you follow the wire and using fluoro, you're going to end up way too deep, and that's not what you're trying to achieve. Remember, you're trying to create a connection with the stomach and the fluid collection. So I think let's push the wire where it is, try to coil it somewhere.
Yeah, it will coil down here.
Okay, all right, so that's our access point. Okay, very important now to use cautery. Okay, that's it. So you see my wire here is very visible by EUS, and that's going to be a procedure that is going to be very, very driven by EUS guidance. Here it is. So I'm going to keep the wire by EUS in front of me. We're going to exchange.
In
You
which
see?
anatomic structure is the distal part of the wire?
I think the wire is probably through necrosis into the retroperitoneum. That would be my guess. But as I said, I'm interested in draining the necrosis, which you can clearly see the wire is through. So I'm going to basically now use cautery, create a track, and then immediately deploy a Luminapose metal stent. Here
And
it
this is something which is a kind of natural cause of wall-off necrosis along the colon, the paracolic gutter, as I think it's called.
Yes,
And this is where you often see necrosis extending to.
yes. And for people that do direct endoscopic necrosectomy, sometimes when you get inside the fluid collection, can I have a cystotome? When you get inside the fluid collection, you see that there's like small little cavities and small
Definitely.
little opening at the very end. And you don't want to go there. And you have to be very, very cautious and use cross-sectional imaging wisely to finally follow up those patients. Do not make the mistake of skipping cross-sectional imaging or repeating cross-sectional imaging. You know, dealing with necrosis is an ongoing process, and people that do necrosectomy tell you that typically you need at least 2 to 3 sessions to deal with complex necrosis. Here it is. So you see, I like my angle. I have my wire into my field of vision. Am I connected? I'm connected. So I'm going to now go into the fluid collection. Here, I'm going to adjust my angle. Here. That's it. And now I'm in. Very important to make sure that I have that shaft push against it so I don't create a dehiscence between the fluid collection and the stomach. So now we're going to remove the current and we're going to exchange back. X-ray. Here it is. You see, I'm keeping my wire into my field of vision. Here it is. X-ray. X-ray. Good. Perfect. Hold on. One more time. A little shaft action. I always say to my fellow, nothing like a shaft action. I'm talking about the endoscopy, obviously.
Obviously.
Here it is. Very important to keep your stability. And now what I would like to do is I'd like to have, I would like to put a lumina metal stent. I think most experts in the room will agree that this is necrosis, this is complex, this is mush. At this stage, you are basically going to move on with, placing a large stent, a large lumina metal stent, and eventually repeating direct endoscopic necrosectomy. So we know from recent data, actually, recently published, that once you deploy a lumina metal stent, 30% of those patients will respond, which means,
Without necrosectomy.
yes, 70% of the patient that has a lumina metal stent gonna require direct endoscopic necrosectomy. And actually, I'm very excited because for DW, we'll be presenting a multi-centric European data and American data, and Mark is involved, Paolo is involved in this, and that's going to allow us to actually confirm this data. I want to talk about another type of lumina metal stent. Everybody talk about the dog bone stent that was created by X-Lumina, now taken over by Boston Scientific. There is the twin brothers from Korea. The Spaxus stent, also lumina posing. I don't know if the camera can see this.
Hold it.
Ah, the camera is here. You can see this. So, so you can see a very nice lumina posing metal stent here. Very short distance between the two flanges of the stent. And one more time, the purpose of the stent is to oppose the fluid collection to the stomach, okay? And then in this case, we have the Nagy stent that we're going to be using, which is the third brother of the lumina metal stent, 60 millimeter, a little bit longer in terms of the space between the two flanges, 3 centimeter, which is fine. I mean, I think with 3 centimeter, we'll still be within the bulk of this necrosis without going through it. So you do understand that our priority here is to place a very short, big stent in terms of diameter.
Okay.
I'm going to put that back here.
We go.
We're going to take the Nagy. We're going to flush the Nagy with water. Okay. Yep. The Nagy is basically gets screwed at the very end of it. So what we're going to do is my nurse here is going to advance the Nagy flush with water over the wire. And as soon as I have position into the stent, we're going to unscrew and start deploying slowly but surely. And we're going to have to position the stent so that each flange is on each side of the stomach. Never lose the wire. I highly recommend doing all those procedures as easy as they can be over the wire, because if you have an issue, you can always bridge the stent. And unfortunately, every single one of us has at least one time in his life bridged one of those stents because of misdeployment or the stent being aspirated. You see, I'm constantly doing a little shifting the shaft action to maintain my position perpendicular to the track that I created. I don't wanna lose the advantage of the track. You see, and it's gonna get through very easily. X-ray. Okay, so you see, I am into the necrosis here very nicely. So now I have to be very careful. What I'm gonna do now, I'm gonna open the first flange and use the first flange as a reference in order to know where am I deep into the fluid collection. So let's open the first flange. We're going to unscrew the Nagy and open the first flange. We should be able to see this by EUS and by fluoroscopy, obviously. See, I'm going to make sure it doesn't get sucked in. Here, keep going. Here, I'm maintaining a little bit of tension while the Nagy is opening. Hold on. Hold on. Here it is. All right, keep going. Okay. All right, so we should be open at least.
There you are.
Here it is, we are open. I don't know if we can see by EUS that we are indeed open. The image is not as clear as I want it to be.
Is this the stent?
Here it is, you can see it here. X-ray. You see, it's not fully expanding because
because of all the
necrosis. So I'm going to try to pull back just a little bit. Here it is. It's a lot of necrosis here. Huh? Lot of necrosis.
So you're going to do it
You
EUS
see?
guided all the way, or
Here it is. Okay, start finally to open up into the center of the necrosis.
can you magnify, or?
Finally. Okay.
Well, for the deployment of these kind of stents, you do not need the endoscopic image at all. You make all on the AUS guidance, on X-ray guidance.
And now we can see it here.
We can see here the end of it on the other side. Okay. Okay, keep going. That's it. So you see the importance of using EUS. And at the very last moment, X-ray, I used endoscopy because I wanted to make sure that it will oppose on the other side. So we're going to keep the wire here. Here it is. I don't know if you can see the endoscopic image here.
Yep, very nice.
Okay, very nice deployment. And there's so much necrosis that the stent is not, okay, here it is. We're going to now dilate the stent. We typically dilate up to the diameter X-ray. Okay, you see it finally opened up inside. And it's not fully open yet. It shows you there's a lot of necrosis. Hold on. Let's
Yeah, I
let's
think
go
we-
together. Okay.
We plan to dilate the stent.
Yes.
Marcus,
Yes, with the
suggested
8
to
millimeter
dilate.
balloon.
Yeah. Oh, yeah, we of course,
Yes,
dilate.
the balloon is ready.
Okay, good. So we like to dilate for two reasons. Mark is totally correct. The first reason is it allows the stent to go to its full diameter, but also we have data that it increased the apposition of the fluid collection to the stomach by foreshortening the distance between the fluid collection at the size of the inner flange and the outer flange. So there's two reasons to dilate. Typically, and I don't know what Mark does, I don't go crazy the very first session. I deploy the stent, and then I come back 2 to 3 days later to do the necrosectomy. I very rarely, go inside the fluid collection as soon as I deploy it. I like to let it, sit there, oppose there, get stable there. So we're going to dilate to the diameter, it's 15 millimeter. What dilate? What? Okay. I mean, you can dilate all the way up to the size of the stent. So we can go all the way up to 15 here.
This is 8.
8 is fine. I mean, as I said, all the way. Let's dilate X-ray. Here we go. You can see the waist. Here it is. Okay. So we can already decide based on the length of the stent on X-ray how long of a pigtail we need. So there's two reasons to place a pigtail. First of all, when you have debris, it's very easy to have the debris occlude the stent. Number two, when the necrosis collapses, the inner flange of that fluid collection can rub against the extremity of the fluid collection and make it bleed. So this is why a lot of people, including myself and Mark, like to put a little pigtail. So it will be a mistake here to take a very long pigtail that will track through the fistula here. So in all the contrary, we need to take a smaller pigtail that will end up into the fluid collection and not into the fistular tract. So I think here a pigtail of 9 centimeter maximum, or 8 or 9 centimeter, will be more than enough.
Seven French or?
It doesn't really
Doesn't
matter,
matter,
7
no.
French. I'm more interested about the length here than anything. A button down, please.
Not too long.
Not too long. I wouldn't go anything less
you,
than.
You would prefer you would prefer double pigtail over nasocystic catheter in this
Well,
case?
I mean, you could place an endocystic, but we know we're going to come back in 48 hours regardless. Let the stent oppose, let the stent settle down, and then you can come back and go more crazy. Balloon down.
If the patient just responds to what you're doing today, why would you go back?
Exactly. As I said, this patient now has 30% chance of responding without direct endoscopic necrosectomy. I totally agree with you. This is why there's no reason.
Do you think there's
this is
do you think there's any role for stopping PPIs? And there's some people saying now if you stop the PPIs, the acid
No,
from the stomach will go in and clean out the collection.
I think that's really irrelevant. I mean, you know, you're talking about mush. Whether you have PPI or no PPI, it doesn't really matter.
It's the,
This exchange
we
here.
saw the same thing actually in the Panther trial where we compared minimally invasive or step-up therapy for
Exactly.
versus surgical necrosectomy. That 30% or a little over 30% actually of patients were treated by percutaneous drainage alone, which is about the same. So even though we think this is infected necrosis, this will not go away spontaneously, up to 1/3 of patients will benefit from drainage alone. And it doesn't really matter whether that's endoscopic or percutaneous. So that's completely in line with what we found in the Panther study. And interesting, I think this year for sure, we will know the results of the tension study, which we'll, where we randomized percutaneous drainage versus endoscopic drainage in severe acute pancreatitis with infected necrosis. So that should be very interesting as well.
I think
In this study, we only used the plastic stents, so not the metal stents.
I think there is a role for inserting in some cases nasocystic drainage to infuse antibiotics.
I'm all for antibiotics. Yeah, well, I think the main problem in wall of necrosis, infected wall of necrosis,
now we have to be very careful
is
because we
drainage.
want to make sure that pigtail doesn't get to the fistula here. X-ray? X-ray? X-ray, please.
Scopy? Scopy?
Can I have X-ray, please? Okay, here. So you see, there's no need to go any deeper. There is no need, because if I go deeper, I will actually facilitate the fistula. So I'm going to ask my assistant to very gently start forming the first pigtail. You pull the wire. I want the first pigtail form right here.
I think it's about in for 1.5 meters or something.
Exactly. It's like it must be somewhere in the cecum. Keep going. Very important to use fluoro. And for this part of the procedure, fluoro is indispensable. Keep going. Keep going. Here you go. Keep going. Perfect. Okay. Now, you see, now I'm comfortable. So now we're going to deploy the rest into the stomach. Doesn't matter the length. One more time. Go all the way, all the way, all the way, all the way. X-ray. Perfect. That
That's
is
nice.
exactly what you
Very
need to
nice.
do. The mistake here will be to push it all the way through. You don't want that because this necrosis needs to drain through the lumina middle stent, and this will seal by itself. So now we have 30% chance, as we said, that this is all the patient needed. Cross-sectional imaging will be repeated within 24 to 48 hours, and then we can decide what to do. Thank you, Professor Giovannini, for this beautiful case.